Well, I don't have a lens anymore on the right side.
It's just
I have a
glass.
cataract fixed on the right. That's what wasn't here.
How was the recovery? Wasn't much. I mean, they do the whole thing while you're awake, right? You're just sitting there.
Yeah, what they do, they use this propofol because I think they have to sort of block the face. I don't know why you drop. I don't think you want to be awake to that.
I would want to not be awake for that.
But then they wake you up, and you're in sort of twilight. You see, you look up and you see a light, you can hear the surgeon, you don't feel anything.
Cool. That's pretty slick.
Yeah, you have to put drops in. You have to put 4 drops in. You learn what these drops cost. Little eye products.
Oh, yeah.
Pay
Pretty amazing, aren't they? $100.
$40. 3 ml bottles.
Are you sure?
They told me without any insurance, it could be about $1,000.
Yeah.
For like, like liquid gold.
Very, very punchy where they were at all times.
Oh, yeah.
Like the doctor, I think you were here. Exactly.
One good day at Steve. I hear it. No, almost two stroke.
Dropped at 14.
Pretty much.
No, I missed you on Hawaii.
I heard it was really nice. I saw the Kennedys and the wife of that.
I don't know what the rumors are doing at Steve. Way better than this one.
I don't know what I expected. They've only got one.
No, you didn't do anything wrong, but there was something all screwed in the system. There was a lot of gibberish. I'm just curious.
Oh, well.
Were you aware of that while you were starting?
I didn't know when I went back on Saturday. I didn't see
I knew something was up.
Already.
Let's see how they years policy I went ahead and signed it. Then realized I can feel all that gibberish.
That can be ugly.
The guy who's been.
Yeah, the chart's okay. So the chart was still good, but you wrote it. I made a couple of corrections.
So hard to go.
Those just all this nonsense.
Especially at 7. Yeah, they had the XD.
Yeah, and I think that they're an acid.
Buttermilk.
Just
That's just got to be more and more insane. I mean, I
Down backwards and then
triple flips on the
No, I
side.
think it was a broader problem. There's nothing that you would involve in at all.
I'm actually fairly impressed by it.
I'm so tired.
Who can tell you probably this because it happens so fast.
Yeah, but that's sort of at an air show. He did something else. What does that mean? He did makeup and stuff.
come back and just vlog it. I couldn't even find the icon. Whatever.
Oh man.
The nurse that shows that I couldn't get Do any of this. Or Dr. Home. I can't figure out.
It's not actually.
She just has to know that.
Yeah. So that's not.
It's not very common. But, you know, it's nice. We had one of the dermatologists ever told us how to get off the house.
Yeah,
And we have
the spa bill is almost as big as my golf. Or maybe it's even.
I probably go in.
Yeah, I'm in Seattle. I didn't wear my seatbelt.
Burning out.
No, we don't. Friday. Did you guys see how
I know it's Tuesday.
No, Friday.
About every other patient yesterday, Everett had a
Oh, I know. Well, and then last Friday was, they didn't tell the doctors, but it was Blue Friday. Everyone
You got back late.
Oh, yeah. Not to celebrate.
They're incentivized to see
zero strain.
not very attractive.
Yeah, very
Society.
Right, so I don't know. I know, it's just
they're just totally so much. We've had pretty soft schedule. And everything that's elected.
So hard to order beer anymore.
Let's go ahead and get started. I already got Mike Weiss. I know you're listening. I got your text here that we got lots of audio static. Everything in the room seems fine, but Drew will go online as if he was an outside listener and see what's going on. If we can, we'll correct it. Actually, I'd just make a comment. Last week I didn't come because I had cataract surgery, so I got up and I listened to it at home. And at least from my point of view, it's a vastly less enjoyable or educational to do it from home. You learn a lot more, I did anyway, from sitting in the room with your colleagues here. You stay engaged a lot more. At home, I just wandered off and stopped listening. But maybe I do that all the time anyway. What else can I tell you today? Mike Martin is going to try and get through this. He's got a rough cold, but he's a real trooper. He's going to do his usual update on metal allergy. But I saw a patient about a year ago with burning mouth syndrome. I didn't know what that was, and I didn't know how it was different than oral allergy syndrome and a variety of other things. So I asked him to do a very pragmatic clinical thing where oral manifestations of allergy or things at least that confuse us as allergists would be worth knowing about. So he's going to give us an outstanding presentation this morning.
That is, I'm not happy to. Well, thanks to everybody for either showing up or logging on so early. I've spoken to this group a couple times, always really enjoy it. It's been about mucosal disease and oral allergy from dental materials mostly in the past. Today, as Len said, I'm going to give you a little bit of an update on what's been going on and also a little background about how I got interested in all of this in the first place many years ago with Marshall Welch, who I'm sure all of you either know or know of. And then I'm going to sorry to interrupt. Go ahead. Is that okay? Yeah. See if that helps. And then I'm going to talk about something actually called burning mouth syndrome, which you may or may not have heard of. But then I'm going to show you 5 mini cases of things, patients of mine whose chief complaint was either oral burning or amongst the chief complaints was oral burning, but only one of which turned out to be burning mouth syndrome. And I wanted to make this, as Len suggested, very clinical, because I think that's going to be the most useful thing for you in your practices. So many years ago, something like 15 or 17 years ago, don't have any disclosures. I got some NIH money to try to develop an intraoral patch test. And then I met Marshall Welch, who enthusiastically agreed to join me in this project. And the fact that none of you are laughing out loud right now tells me that you didn't see the glitch in this either. Well, but you will. So this was our idea. We would make these thin plastic suck-down devices. We call them stents, over models of patients' mouths. I created fin chambers in them by putting little buttons on the mold, as you can see here, and that created little fin chambers. And then the allergens would go in here up against the palate. Well, the glitch, of course, and the NIH reviewers, I guess, didn't see it either because we got all that money, was that the palate secretes all of the time. Doesn't, and it secretes a lot. So the allergens would mix together. And so then I tried scoring the mold in between the fin chambers to create little ridges that would push up into the palate and hopefully keep the allergens separate. Well, that didn't work either. So then we thought, well, we've got to figure out something else. So I had the brainstorm, I'm not going to blame this on Marshall, of trying an intraoral iontophoretic approach to delivering the allergens. So I took ionophoresis pads and cut little holes in them, creating little fin chambers, and then got aqueous versions of the same allergens and put them on little paper pads in here. And we wound up with something that looked like it was from Silence of the Lambs to work with our patients so that we're iontophoretically driving the allergens into the buccal mucosa of the cheeks. Believe it or not, it actually kind of worked. Kind of being the key word here. But that's how I got interested, training with Marshall and trying to develop this project, which eventually we just sort of threw away. But since then, I've been doing a lot of...
Is that a medical student?
That poor man was a genuine subject. Yeah. And I've been doing a lot of the standard patch testing using the ICDRG guidelines and a dental materials panel full of methacrylates and metals and so on. And so I want to show you what the current results are of my group of patients. So it's really just a very long case series compared to what I'm going to call the general background response rate for the metals that are in this panel. So to do that, what I did was I did kind of a systematic review of all of the derm literature I could find on what you might call background rates for reactions to the metals. Now, nobody goes and tests normals, so everybody that got tested in all these various studies had something wrong with them, so we can't really call this a normal background rate, but it's the best thing we've got. It's the best proxy that we've got. Currently, I have one of my master's students doing a real systematic review, and we'll wind up publishing that sometime in the next year, because nobody's done that, really, to look at the real worldwide background rates for each of these metals. But here's what I'm going to show you. In the graph I'm about to show, there are 137 patients. This is an update from the last time that I showed. 103 females, 34 males. All of them had lichenoid changes in their mucosa or lichen planus. 74 of them had what I'm going to call biopsy-confirmed lichen planus. That doesn't mean that the rest of them weren't biopsy-confirmed. It just means they hadn't had biopsies. Or they'd had a biopsy and it came back as a lichenoid mucositis or something like that, if you will. There are the mean ages. And this is pretty striking when you look at it. The purple are what I'm going to call the best estimates I could get from combining all of the various studies I could find that used each of these metal allergens. Chromium and nickel, in particular, I have a little note on the bottom there because they had very wide ranges reported. Most of the studies reported ranges that were fairly tight. But nickel and chromium, for some reason, had these really wide ranges, so I did my best guess. But I think it's pretty striking when you look at the differences between my so-called mucosal disease patients and the general population, except for mercury, aluminum, tin, and zinc. And I'm not a chemist, and I need to sit down with a periodic table and try to understand why this would be. Maybe you guys can tell me. But this is pretty striking. And these metals on this side are the ones that are primarily used in your mouth. Mercury has been used a lot. Mercury gets a lot of press, but the truth is mercury is just not a big deal. But I don't know, this is pretty striking. So I'm beginning to think that a lot of what we call lichen planus isn't autoimmune, but rather immune. That it is some kind of allergic thing. So that's it. That's all I really wanted to tell you about the update. So that's the end of my update and the end of talking about my crazy ideas. And now we'll move on to burning mouth. So burning mouth, yes, sir.
Do you find gold is that common? More common than cobalt and nickel?
I mean, well, these are the.
I mean, obviously.
Yeah, this is it. And then I'll show you a case, one of these 5 mini cases, and I can talk about that a little bit more then.
But why can't you just do skin patch testing? Why the?
These are standard skin patch tests.
Yeah.
Before you move away from metals, is there the most common thing we have to deal with is joint replacement surgery. Sending it to you. Is there anything new, pragmatic you should tell us about that?
No. I keep getting referrals from all kinds of orthopedists and allergists as well. People, pacemaker, dermatitis over pacemakers, dermatitis over joints, that kind of thing. I don't ever see anything from titanium, but you see a lot from cobalt chromium, sometimes from the plastics and so on. But no, there's really nothing since we last talked. And I don't have any sort of systematic research going on in that arena. So when you guys see oral burning, I'm sure that it can be confusing to you. If you look in the mouth and you don't actually see something, you've got to be thinking, well, could this be an allergic reaction to some exposure that they've got, or in fact something in their mouth, or what could it be? So I'm just going to talk about primary burning mouth syndrome briefly. Typically it's spontaneous burning in the oral mucosa. It's almost always bilateral and symmetrical, but it can be persistent or recurrent. Primary, meaning, of course, it doesn't have a known etiology in particular. We know it's a neurologic dysfunction of some kind, but no one knows whether it's local, whether it's central, exactly what mediates it. Secondary can be to a concomitant disease or some kind of oral or parafunctional habit. When we talk about parafunctional habits, we're talking about things like clenching, grinding, sucking on things, playing with your mouth. People do all kinds of weird things with their tongues. They're just playing with their mouth and so on. And you can really produce all kinds of oral burning from that. You can certainly produce changes in the tongue, surface texture of the tongue that might look like an allergic reaction, or the roof of the mouth, buccal mucosa. And then we can never separate the psychological from anything else, so psychogenic factors certainly produce oral burning. So it's a diagnostic dilemma. We live in Seattle, so we see a lot of piercings. I don't know if you guys have run into this. People that want their tongue to look like a snake tongue, so they have their tongue split. And when I think of oral pain, these things are out there. So I want to talk briefly about the local, the systemic, and the psychosocial factors. So local. I thought it was fun that the key word today was xerostomia, since that's one of the things that can certainly produce oral burning and produce visible mucosal changes. And it's pretty easy to not realize that somebody's xerostomic. A nice, simple way to do that is to have them just sit still for a minute and raise their tongue a little bit and look in the floor of their mouth. And if you don't see saliva actively pooling in the floor of the mouth, they're dry. Very simple, very quick way to say, maybe you're a bit dry. And then you can try to bump up their salivary flow with pilocarpine or another medication I'll talk about in a minute for a month or so. And if the oral burning goes away, it was due to their xerostomia. Dysgeusia, certainly is associated with burning mouth syndrome in probably about 20 to 30% of the cases. No one knows why, but they'll often report a salty or metallic taste as well as the oral burning or the oral discomfort. Infections, clearly, like Candida, can produce oral burning as well. I'm going to show you a case of that. And then there's lichen planus, migratory glossitis, fissured tongue, benign mucous membrane pemphigoid, all the things that you know that they're obvious might produce oral burning. Parafunction, I mentioned that before, and these things can actually produce some pretty interesting oral burning syndromes that are really just related to what the person is doing, usually unconsciously. Oral galvanism. Now, this is where you've got dissimilar metals in constant contact. So you've got a gold crown on this tooth, and immediately adjacent to it, you've got, let's say, an amalgam filling, mercury amalgam filling. By definition, that's a battery. Electrons are being exchanged. You got an electric current going. It's a very minor electric current, but it's been well documented that that can produce actual cellular changes in the tissue, and so you can actually see something, but it can also produce this sense of oral burning, and it's not that unusual. I published a paper in Contact Derm back in 2003, I think it was, where we did a case control study looking at patients with lichen planus or lichenoid changes versus controls, and we looked specifically for the presence of dissimilar metals in constant contact or oral galvanism, and we came up with an odds ratio of almost 6 if you had a corroded amalgam touching another metal, so the evidence of high oxidation rate, so a higher galvanic response, odds ratio of 1.25, but with a significant confidence interval just for having dissimilar metals touching. So there's something about galvanism that can produce this as well. We didn't look at burning at that time, just at the presence of the lichenoid changes. By ill-fitting teeth, I just mean dentures, right? Or a crown or a bridge or something that isn't right. But then also allergic reactions. And from the very first part of this discussion, you can see that there's a lot going on there. And I'll show you a case of that. The systemic factors, everybody reads and talks about nutritional factors as being a factor in oral burning. And the truth is that my colleagues and I, the two that have been there a little bit longer than me, we've got something like 110 years of combined experience, and we've had maybe 5 cases ever where we actually found a nutritional deficiency producing any kind of oral burning. In fact, we don't even test anymore unless we can see something very clearly like a tongue that looks like this, very atrophic, erythematous, glossy. We don't even think about it, at least in America. Now, in literature worldwide, you'll find all kinds of cases where, and studies where, in fact, nutritional deficiencies did relate to oral burning and so on, but we're just not finding it. Autoimmune things, Sjogren's, lupus, lichen planus, benign mucous membrane pemphigoid, all of those, again, can contribute. Endocrine, diabetes can produce oral burning, thyroid changes, I'm sure you're aware of that, and then hormonal changes and deficiencies. And I'm going to show you how that relates here in just a second. Some of the CNS disorders like MS, Parkinson's mainly from movements.
Is there still considered a link between Hep C and lichen planus? Or
Very much so.
Okay.
Very much so. Still very poorly understood, but you bet. And then, of course, trigeminal neuropathic pain can be a source of oral burning as well. I think one of the cases turns out to be that. And then the psychosocial, and you can't, we all know this, you can't separate the psychosocial from the rest of the body. We use something in our clinic called the SCL-90, the Symptom Checklist 90. It's a very old, well-validated scale with 90 items on it, looking at depression, anxiety, and somatization. We have a revised version that's got, I think, 32 items or something like that, but we validated that as well. And we pay a lot of attention to that in terms of oral burning, because the psychogenic factors can often play a role. Even if they're not the primary factor, they'll certainly make it worse. If somebody's got a level of depression or anxiety or somatization about what it is that's going on with them, it's the fear of the unknown that makes us all worry a lot more about what's wrong with us. So there is precious little high evidence-based medicine level research about burning mouth syndrome. Very little. Here is an example. This is a study done in Croatia. And this is on normals. They took 150 normal mucosal appearing subjects, but who noted oral burning. And they found that 40% had, and these are not mutually exclusive categories. There's overlap here, but 40% they found Candida. Now they did that by culturing Candida. Well, hell, everybody's got Candida in their mouth, so I'm not sure about what that actually meant in this study. 40% they rated as xerostomach, 13% with diabetes, 13% with anemia, some galvanism, and other neurological diseases. I know for a fact that the Candida and the xerostomia just aren't right. But what I don't know is what was wrong with that study. But again, this is the kind of study that's out there trying to figure out what kinds of things are associated with burning mouth syndrome. There just really is a dearth of research on it. So I know it's a journal club, but I can't talk to you much about the literature on burning mouth syndrome in terms of actual evidence-based studies. The characteristics of true burning mouth syndrome are primary, is that eating or chewing or any kind of oral activity typically makes it better. People will tell me if they're chewing gum, they don't notice it. If they're eating, they don't notice it. If they're talking, they don't notice it, or not as much. And of course, that's just counter-stimulation, probably. That's either they're just not paying attention, or in fact, it's shutting off the nerve impulses that are creating the actual oral burning. Typically, it's worst in the evening, just like this post-viral cough that I've got. The majority do report feeling that they have a dry mouth. Whether or not they have a dry mouth, they'll say their mouth feels dry, sandpapery, and so on. And that seems to be associated with the onset of the oral burning. And interestingly, most frequently, they'll talk about the anterior half of the tongue and the anterior palate. We don't know why, but that becomes relevant in one of the cases that I'm going to show you. So what do we do? Well, the current treatment modalities for VMS include behavior mod, because of the psychosocial aspects, and counseling goes in there, but the mainstay is clonazepam. If you guys think you have a patient with burning mouth syndrome, try them on clonazepam. We don't know why the other benzos don't do it. We talk about the use of tricyclics, membrane stabilizers like gabapentin or carbamazepine, these kinds of things. Capsaicin is just a counter irritant, right? I bet you guys use that too. So those other things work okay, but if you want to do a diagnostic trial, put them on 0.5 of clonazepam, BID or TID, and if they're not too sedated and their burning either goes away or is significantly modified, it's burning mouth syndrome. And again, we just don't know why. It's clonazepam in particular. And then you titrate the dose, and patients are typically very happy. And interestingly, all these other things that burning mouth could be, clonazepam doesn't seem to help with. It seems to help with primary burning mouth syndrome. And we do have one new crazy idea. Universities are hotbeds of crazy ideas. And so because our patients had been telling us that it was the anterior half of the tongue and the anterior palate, and had told us that frequently that when their tongues touched the roof of their mouth, it seemed to ramp up the burning. Almost 2 years ago now, we started taking those same stents that I tried using for patch testing and just putting in a stent, kind of like an Invisalign brace device, so the tongue can't touch the palate. Remarkably, and we haven't quantified this or done a case series yet, but I'm going to say at least 90% of our patients report significant reduction if it's primary burning mouth syndrome, when that's in. They can't keep it in when they're eating. They often don't need it when they're sleeping because burning mouth seems to drop off during sleep. But when that's in, it's amazing. And they can either discontinue or significantly reduce the amount of clonazepam that they're using. So, it's clear there's some neural feedback, some pathway going on that we haven't identified yet that we can turn off just by using this nice, simple, reversible, non-medication gizmo. But clearly we've got a long way to go. Now, I don't know about you guys, but when I see something like this in a talk, my eyes roll back in my head and my head spins around in my neck, and I want to leave the room. So I'm not going to go through this. I'm just showing you that we have an algorithm for diagnosing and treating burning mouth syndrome, and if anybody's interested, I can get you a copy, so let me know. Or maybe you can get it from this, from the presentation. But so now I want to give you 5 mini cases Actually, you know, I'm sorry, I did want to mention a couple of other things. Two other things that we often use for burning mouth. One is, now this is another crazy idea. Doxepin, antidepressant, comes in an oral solution for people that don't like pills, right? If you mix Doxepin 1 to 5 with water, 5 parts water, 1 part Doxepin, and have the patient swish with it for a minute and spit it out, they'll get profound oral numbing that'll last up to several hours, unlike the use of viscous lidocaine or something, which only lasts 15 minutes, half hour, or something like that. So that often helps a lot, and that's true whether it's a stomatitis or a lichen planus or anything else going on in the mouth. So I'd put that in my armamentarium if I were you guys, because it's easy, central effects are about zip, and they can get through a meal or they can get through a party or a discussion and feel relief. All right, so I'm going to talk about a true burning mouth case, a trigeminal neuropathic pain case, and all of these presented as oral burning, my mouth burning, a xerostomia case, an actual allergy case, and a sinus infection case. So case number 1, this was back in 2012, 56-year-old Caucasian female, going through menopause, and that is classically the burning mouth syndrome patient. The average burning mouth syndrome patient, if there is such thing, is a peri or postmenopausal female. So we know there's got to be a hormonal connection. Nobody knows what it is. HRT doesn't change it, so we don't know what that is, but we know that something about that. Did office work, married. She'd had an appy in 97, twisted bowel in 06, blocked bowel in 10. And the only prescription that she had been on, and wasn't on anything at the time that I saw her, was gabapentin for knee pain. And here's what she said. She had a burning sensation, and she had this dysgeusia that goes along with it, the salty, metallic taste. And they'll often tell you, yeah, it tastes like there are nickels in my mouth. I don't know what it is about nickel, but they'll talk about that. Her GP had given her a 2-week trial of omeprazole, thinking that it could be reflux. And of course, you always think about reflux when you talk about oral burning. It can produce that, and I failed to mention that earlier. She'd been scoped. Nothing was there. The SCL, so the Somatization, Anxiety, and Depression Scale, was completely normal for her. I did salivary pH testing, normal. By the way, you never find salivary dysfunction in burning mouth syndrome. I've just about given up on that too. Her head, neck, and oral exams were completely normal. So my differential was dysgeusia and burning mouth syndrome. Sometimes if they talk about taste disturbances, I'll think about smell and taste testing just to see if, in fact, that's a completely separate entity just going on at the same time. But usually I'll save that until we figure out whether we can just turn off the burning mouth syndrome and that the taste and smell alterations were just a part of that syndrome. And by the way, when the burning goes away, the taste and smell goes back to normal when you're treating somebody with clonazepam, for example. And then, you know, you always have to wonder, okay, is there something central? And so if we just can't figure out what's going on with the case and we can't get it fixed, then we'll consider an MRI or an MRA and look for something central, or something in the distribution of the trigeminal nerves. And occasionally we'll find something, but we don't do that very often. So at a follow-up, the clonazepam worked very well and very quickly, and she was essentially cured. And it was going on 1.5 years, so she was pretty happy. But clonazepam can be kind of sedating, and for her it was. So we thought about one of those stents. She asked about zinc. I'm sure you guys hear about zinc when it comes to taste dysfunction, and maybe you've heard about the use of zinc for oral burning. That's on our algorithm. It doesn't work. So you can find articles that talk about it working, but again, virtually no one, at least that we see, actually has any kind of zinc issue, and so we don't think about it very much. But she wondered about it, so we talked about it, and as you may know, it's easy to overdo the zinc and then wind up with neurological problems. So I gave her a stent, and this sometimes happens. The stent worked really great for the first couple weeks, and then the effect dropped off a bit. So there's some neural compensation, whatever it is that's taking place wants to take place. But the stent still worked pretty well, but she was able to reduce the clonazepam significantly and pretty comfortable. But then she started to note this xerostomia also, so I put her on pilocarpine. and that bumped her salivary flow up, and she's doing great. I mentioned earlier there are 2 approved drugs for increasing salivary flow. One is pilocarpine. You typically treat at 5 milligrams up to 6 caps a day. And then there's something called cevimeline, which is just a newer medication, and it does the same thing. It bumps up exocrine function. If you're going to give somebody pilocarpine or cevimeline, warn them that they're going to sweat a little more at first, and that their eyes might water a little bit at first, and that they might get a little bit of a hot flash 5 or 10 minutes after each dose. All that goes away after they become accustomed to the medication. Am I going too fast? Case number 2. So this was a 36-year-old female. She did structures assembly on airplanes at Boeing. She was referred by her ENT, and these were the things that had gone on with her: history of migraines, obesity, back problems. She had a lap band. She was taking tramadol, Xanax occasionally, and Zofran because of the lap band. She needed it every now and then. She said her tongue was really burning, her mouth was burning, she had to just use it, and she had numbness, all left-sided, and this had been going on for about a month. And her tongue didn't work right, so she was biting her tongue, and she said, the surface of my tongue looks funny. So in the history, I found out that in September of 11, she'd had an inferior alveolar block, like dentists do to work on either half of the lower jaw, and she felt a jolt during the injection. I'm sure some of you have too. I have. You know, the dentist is going to run the needle right through that's a big nerve. They're going to run the needle right through it sometime because they don't have x-ray vision. And then she had a second injection, and she felt the numbness spread to behind her eye. So I think what happened in that case was the dentist delivered the second one a bit high and managed to capture part of V2 as well. So I did just some basic neurosensory testing, and all I do is I break a Q-tip in half, and I pull out a little bit of the wisp on one end and use that for soft touch, and use the sharp, pointy end of the stick for pinprick, and just do bilateral testing. And sure enough, she had loss of sensation on most left half of her tongue. And then I looked at it. Well, I'd already looked at it, and it looked funny too. This isn't her tongue. I didn't get a picture of her, but it looked just like this. So she'd actually had the loss of the filiform papilla on the surface of the tongue. So there was atrophy taking place because the nerve function had ceased in that area. And the patient said, you know, I think it was the Novocaine. Now, as you probably know, we don't use Novocaine anymore. It's lidocaine these days, or carbocaine. But during the visit, I contacted her dentist because, and I'll bet you don't know about this, there was a new anesthetic introduced, I think in 2000, into the U.S., approved by the FDA then, called Articaine. And the brand name is Septicaine. And it had been used in Europe for some time before it got approved here. The anesthetics that are typically used in dentistry are a 2% solution. Articaine's a 4% solution. And it's bad juju. Don't let people use that on you or anybody you care about. There are other reasons why it's a problem, but it is producing a lot of post-injection neuropathic pain, so nerve damage. It's not well. If you Google it, you're going to find that, yeah, it's out there. Everybody knows about it. I think there are class action suits forming up. But because we're a tertiary referral center, we see all the weird stuff, and I see a lot of post-septicaine neuropathic pain that we don't know yet. It could be permanent, could be transient, we don't know yet. And the dentists like it because it acts very quickly. Hell, it's 4%. You know, you get in there, you get the anesthesia going, and off you go. But it's a very bad drug. I wouldn't use it. And so I called the dentist, and sure enough, she'd had Septicaine used for both of those injections. So I thought, well, this is post-injection neurologic damage. So I tried her in gabapentin. At a month, she had titrated up to 500 a day, which I know isn't very much, but we go slowly. And her oral burning had diminished somewhat. Pain behind the eye was gone. But the gabapentin made her too foggy. So we reduced it and added in a tricyclic antidepressant. You know, I mentioned earlier that the tricyclics can be useful in oral burning as well. Long story short, ultimately she just couldn't tolerate the membrane stabilizers or the tricyclic. And so she wound up on hydrocodone with an opioid contract. 2 years out from this, I'm just maintaining her in that way. and we're thinking about switching her to a CR or a controlled release medication or a patch, something like that. So this was a case where oral burning was actually caused by neurologic damage. This was an 83-year-old, very nice lady, retired teacher. She came in and said she'd had oral burning and tissue changes for 3 months. History of thyroid. What did I do with my cloth? Excuse me. She was taking a thyroid supplement, AFib, and arthritis. She'd had a total hips in 90 and 93 and a total knee in 93, or 03, I beg your pardon. These were her medications and a couple of vitamin sups. And she was complaining. I loved this. You know, she's 84 and she's complaining because she had back pain because she got this exercise DVD and the darn thing made her hurt her back. She had vaginal labial changes for years with a plus-minus course. In her mouth, she had this, in addition to the burning, sandpaper feeling of tongue and gums. I look in her mouth and she's got Wickham striae. She's got what looks just like lichen planus in there. And on the bilateral lateral tongue as well. The dorsum of the tongue was normal. Interestingly, her primary care doc had told her it wasn't endocrine or autoimmune, and of course lichen planus is autoimmune, so I'm not sure what the misunderstanding was there. But then I looked further in her mouth, and I saw all these mucoceles all over the place. Little mucoceles on the palate, the posterior pharyngeal wall, I think. Yeah, here's some little mucoceles in the buccal vault, buccal vestibule here. And so I thought, well, what in the world's going on here? And I did a real quick assessment of her salivary flow, and she was very dry. And all the other things she had said led me to think. And so my theory was, and I'd never seen this before, neither had my colleagues, so none of us in 100 and some odd years of experience had seen anything like this, but I thought, I wonder if she's so dry that the minor salivary glands are just epithelializing over and then filling up with saliva. So I put her on, here also are the lichenoid changes, you can see very clearly, of her gingiva. So this is a case where there's clearly lichen planus going on. So I put her on pilocarpine. Sorry, getting ahead of myself. The burning wasn't a big deal to her, but she avoided spicy foods, and she said, of course, I don't drink alcohol. So I talked about the lichen planus and the management of that, but separately put her on pilocarpine. And when she came back on 4/12, the mucoceles were essentially gone. So I think the theory was right, and the oral burning had dropped off dramatically because the burning that she was having was primarily because her mouth was so dry. Okay, no, the 412 was this patient, I'm sorry. So this case 4, chief complaint, oral tongue burning since 2 of 11, school counselor married. These are the things that were in her past medical history. I'll read through that for a second. She couldn't remember when her gallbladder was removed, late 90s sometime. She was on fluoxetine, nystatin, and she had been taking nystatin for quite some time. So this was a course of her treatment since the onset. She'd been seen by her GP, her ENT, her dermatologist, her allergist, and 2 infectious disease docs. And she said with great certainty that every time she gets an antibiotic for anything, she gets a yeast infection. And that's why she'd been treated with so much nystatin and diflucan over the years. In February of 11, she'd had antibiotics and prednisone for an ear infection, and bingo, got oral candida after that. So she'd been given diflucan and nystatin, and the oral symptoms had dropped off. Then I looked at her, and this is what I saw. What I see is that the rest of her mouth looked very normal. There are atrophic and lichenoid changes here, gold here, atrophic and lichenoid changes here, and a big ulceration here, and that sits right there, right next to these 2 gold crowns. So I thought, well, okay, this could actually be tissue-borne, or what I call atrophic candida. You know, we're used to thinking of oral candida as thrush. The truth is, we see a lot of cases where there's no evidence of thrush whatsoever, but there are important, significant lichenoid changes or even ulcerations, typically in the tongue, sometimes in the buccal mucosa as well. And it's candida, but it's candida that's deeply into the stroma of the tongue itself. So, you know, my differential was that it could be tissue-borne candida, but I was pretty suspicious about the gold sitting right there as well, and maybe this had been a misdiagnosis all along. because there was just no other evidence. And as you may know, the diflucan, nystatin, most of the antifungals also have anti-inflammatory activity. And so it's not unusual for us to hear that somebody's been on an antifungal and their mouth feels better while they're on the antifungal. Well, it's because the inflammation is being taken care of. But in fact, they don't have any kind of a fungal infection. So, did patch testing. This was at the first read. I don't have a picture of the second read, but that's gold. And the second read was even more dramatic. You know, it was quite the reaction on there. So I suggested that she replace one side, and 6 months later she came in, and the other side that still had gold was worse. Now it's ulcerated and wide open, but the side where she had replaced the gold was essentially healed. Little tiny bit of an ulceration left. Now I've seen a number of these patients where we've done the allergy testing, found the materials, replaced the materials. It takes a long time for whatever the allergic reaction that was causing the tissue breakdown to go away, but it goes away in almost every case. Sometimes, if the patient has a lot of crowns, bridges, something like that, where we can't just isolatedly remove 2 or 1 and wait and see what happens, we'll make one of those stents that I was showing you, and we'll cover all the teeth and just isolate all metals or plastics or whatever, except plastic of the stent, from the soft tissue, and then we wait 3-4 months and see if there's a change. If there is, bingo, go ahead and spend the $20,000 to $60,000 getting the materials replaced. But if it's isolated like this, then you can go ahead. So then,
does topical doxepin do anything? Does the topical doxepin, would that do anything, or could you ever do like topical steroids?
I use a lot of topical steroids for lichenoid changes and lichen planus. And certainly you could just keep treating it with the doxepin helps just for pain relief, and the steroids sure are like a treatment, but of course you want to get the root cause out of there. So in my mind, if you've got a patch test that tells you there's something going on, get the materials out.
Just out of curiosity, obviously she probably had these crowns at different times, but what was the time frame between like having both of those crowns there and then clinical problems?
Thank you. That's a wonderful question, and I don't know in her case, but we see cases where the crowns were put in 2 months ago, and we see cases where they were put in 15 years ago. And my guess is they got sensitized at some point. You guys know a lot more about that than I do.
Does it ever happen with the impurities in the gold set up a galvanic current between one crown and another?
We think so.
Gold?
Great point. We think so. There's good bench evidence for that, but nobody's done any important studies to prove that. This is a similar case, but without the candida. This patient just plain came in and had all these lichenoid changes here, patch test, removed the crown, and things are starting to improve. Okay, last case. So this guy came in June of 13. Came in with his wife. He said, left maxilla, lips, guns, mouth, burning, aching. It's been going on a couple of years. His wife said, this has destroyed our lives. He doesn't want to be with the family. He doesn't want to go to parties. He doesn't want to do anything. It drives him crazy all the time. Health history was this. He'd been, other than the fact that he died once, he had a completely unremarkable health history. He had some carotid stents put in. These were his medications. I call vitamin D vitamin DA now because in the Northwest everybody's on it. So his extraoral head and neck exam was completely normal, intraoral completely normal. Percussion, that's supposed to say percussion of number 14. 14 is the first molar in the upper left. 13 was already gone, that's just a misprint, I'm sorry. Slight increase, so if I tap to that area. Neurosensory testing with the, I shouldn't have told you, except it'll confuse you in a minute. With the Q-tip, he had decreased sensation in the area, both intraoral and extraoral, so out on the cheek as well. His SCL was normal, even though his wife said that this had destroyed his life. I think he was just minimizing as he filled it out. A lot of people do. They had sold their home, moved to a condo, so they were pretty happy. the dentist had tried relieving teeth initially, relieving teeth in the area. When this whole thing started a couple of years ago, the dentist said, I think you're just beating your teeth up, so let's get them out of occlusion and see if it goes away. Ultimately did a root canal on tooth number 13. Didn't help a bit. Ultimately took it out. Didn't help a bit. We see this a lot, unfortunately. So the ENT had ordered a sinus CT, and the report had come back as minimal mucosal thickening in the left sinus. So again, my exam was normal. So I said, well, I wonder if this is just atypical trigeminal neuropathic pain, atypical trigeminal neuralgia. So I tried him on gabapentin, and then I got the sinus CT and looked at it. When he came back, the gabapentin, he was up to 800 a day, and he thought, yeah, you know, maybe it's making a little difference. Probably not, really. Then he said, you know, sometimes I think it's the sinus, sometimes I think it's the eye, maybe the upper jaw. And I got to look at the CT disc. And this is what I saw. So this is the minimal mucosal thickening in the left sinus, but it's directly over where tooth 13 had been. Here's the side view. Here's where tooth 13 had been, and there's pretty clearly something had been going on in the sinus. And it had probably, you know, and to the radiologist, this was not a big deal. A lot of people have something like this going on, but a lot of people don't have oral burning that goes on for 2 years in a particular area. So I thought, well, I bet this is burning pain secondary to a smoldering, lingering sinus infection. I put him on amoxicillin and double dose of Zyrtec with the plan of doing this for about a month. And within the first week, the pain was gone. So, you know, the final diagnosis was that this case of oral burning was secondary to a smoldering sinus infection of some kind. And when I talked to him earlier, he was doing fine. And so the plan was to finish out medications and come back if it got worse. So this is Smiling Mike Tyson. I'm sure you guys recognize him. And this is the take-home message of the talk. And interestingly, I saw a Foot Locker ad on TV recently with Smiling Mike showing up, humbly offering a little gift box to Evander Holyfield with his piece of ear back to him. Comments or questions?
And they use septicane for these dental blocks. Is that with epinephrine or without?
It's with, but you can get both preparations. And of course, that just keeps it in the area longer.
Right, but if you inject the nerve close enough with epinephrine, can you infarct the nerve?
So, in dentistry, when 2% lidocaine is used with 1 to 100,000 epinephrine, and it comes in different strengths of epinephrine, the blocks are done right. You don't actually pierce the nerve, so it's just near the nerve. You get something like 1 in every several 100,000 injections, maybe 400,000 injections. You'll have some, almost always transient, nerve damage. This whole thing with septicane is not understood, but is very real. And I see people with anything from just mild discomfort all the way up to really tragic trigeminal neuropathic pain, having had septicane injections. It's not a good thing. Yes, sir.
We see a lot of people with food-related oral complaints. Do you see any relationship with food and any of these variants of oral burning?
Absolutely. I didn't present a case like that, but it's not unusual for us to, thanks for bringing that up, food or other, another very common cause of oral burning is the kind of allergies that you guys see all the time, cinnamon, certain other, I see some kind of fruit latex things that I think induce oral burning. And then a lot of the modern toothpastes have all these anti-tartar, whitening, anti-tartar, this and that. They produce a lot of mucosal change and a lot of oral burning. And those are nice things, but I think you're better off with just some really simple, basic toothpaste. So those kind of food or topical exposures as well, produce oral burnings.
Well, along those lines, one of the most common physical exam findings from those toothpaste sensitivities is gingival inflammation usually.
What was the first part of that?
So in the toothpaste sensitivity, what kind of exam changes do you see?
Oh, you're going to see basically atrophic or lichenoid changes. You know, mixed erythema, maybe a little bit of striae, leukoplakia. Sometimes it just looks like gingivitis, which is funny because they're cleaning their teeth like crazy and they still got red, you know, irritated gums, but it's an allergic reaction or some kind of just chemical irritant reaction.
But not angioedema, because a lot of our patients come in with idiopathic lip angioedema and they're convinced that something they put in their mouth has caused this.
Yeah, we see a lot of angioedema as well. That's a really tough thing to nail down sometimes.
Yeah, most of it.
Yeah.
Most of it.
You go back to your sort of classic case of primary burning mouth, sort of perimenopausal woman. Just out of curiosity, is that if you follow those patients, for example, if they go through menopause, does it go away?
Thank you. I forgot to mention that. And that's, of course, the first question they all have. Is this going to go away? And the answer is yes. And here's what we think. This is just one of those university crazy ideas. We think, you know, since the advent of PET scans and functional MRI, we know that if you experience something, you burn a neural pathway into the brain. So that the next time you experience it faster. And so we think that burning mouth is like that. So the analogy I use for patients is, if you walk across your front yard 50 times a day in the same place, you're going to cut a groove in the grass. And if you quit doing it, the grass grows back. So we think that if you don't let them experience it with the clonazepam or the membrane stabilizer or whatever, the stent, then the grass grows back. And that speeds up the process. Our algorithm typically, which is not on that algorithm, is to keep the patient on, once they're really under control, you keep them on whatever that is for 3 to 6 months, and then you withdraw. If there's even a hint that it's back, you put them right back on it. No one knows the average duration of the cases, but they go away. And that's very reassuring to patients to know that it is going to go away, or you'll die.
Do you ever go past gabapentin and into Lyrica or Cymbalta, or do you just give up with gabapentin?
We'll run down the entire list of membrane stabilizers before we give up, yes.
And I have one other question on patch testing in their mouth. Have you ever tried to mix their patches with super glue? And try out the membrane and then just apply it so that it would stay there for a couple days?
I think you're on something. Where were you 15 years ago?
Playing with super glue at that point. Anyway.
That's brilliant.
The mucosa is going to replace itself in 2 days anyway, so your patch test would be sort of self-limited, and then it would slough off.
Thank you.
You're welcome.
Put a fellow.
I'm going to call Marshall. That's a great idea. Do you have any idea what it would do to the allergen? Would it?
Well, if it's just a suspension, it probably wouldn't do anything except for dilute it.
Huh?
But the cyanoacrylate, I mean, it's relatively inert. We don't see much sensitivity to that, and they use it in facial lacerations all the time. So, but it just seemed it would give you the ideal: dry out the mucous membrane, glue it on there, and let's see what happens in a couple of days.
You know what? I'll try some just to see if it stays. I'll do it to myself.
There you go.
You're still open for all our referrals of dental materials
Oh, please.
or metal allergy testing, and
Yep, I really enjoy those cases.
you have materials that generally we don't. Well beyond.
That's what seems to be the case. My panel goes up and down over the years. Right now, it's got 30 some odd items. It's been up as high as 40, and then I found that I wasn't getting anything, bang for the buck on some of them and dropped some of them. But it's pretty much anything that could be used in the mouth, anything that's used in hips, knees, shoulders, pacemakers, that kind of thing.
How about chylitis? Is there any correlation with just chylitis in any of your contact allergens?
Very, very rarely. Annular chylitis is almost always candida. And so if they treat it topically with just some over-the-counter antifungal, 3-4 times a day for a couple weeks, it's going to go away. 99.9% of the time.
I have a little girl right now. I didn't know what she had. So thank you.
It easily could be.
Well, thank you.
Well, thank you. Thanks to all your I think there's a significant psychological very intelligent. 11-year-old, really nice, but it's absolutely unique case. Yeah, makes sense. It's stiff. But Clonazepam keeps her pretty well. You know,
Metal rashes showing up, and
It's good to find out.
yeah, I did have one. You said they're still on the website.
No, I know, but
You want to get bored to death.
Yeah, you can never go back.
that's not the same as you dying from a toxic.
Not all redheads look alike.
Is that what it is? No, I know what it is. My wife was a medical student.
That's right. I remember a guy. I really have a question. I just want to say there's controversy and nihilism about testing for metals in our field. And I'm sure
That's one of the more.
and I don't know what to think. There's one who believes, but I don't have much evidence. Well, I don't know whether it's predated like that.
It's not like a cyanide bond.
I agree with you. The systematic reviews that I mentioned that are trying to... I thought we had a guide too. Maybe I didn't say it's becoming obvious that that the evidence to connect what shows up on the dermis to anything else is great.
But I also believe the patients. It's very striking stories. And an allergist will often dismiss it as
Email address. I always try to track that true level. It sounds like you don't need to get true level.
the patients just help the process.
So you're not getting many cases.
I don't do a lot of that.
Boy, you ought to have mucosal disease patients. It's like, and I'm using the exact same
The goal is it ionized somewhere or another?
Well, it's got to be, and you know, saliva is an electrolytic solution, so you're dissolving stuff out. And then you made the point about mixed metals, the alloys, and the derm literature, as you probably know, just in the last decade, has really expanded dramatically about. I thought I was doing something wrong for the first 10
I had
years.
2 gold just in the past 6 months, I think. I only done patch just enough time.
And I don't think that anybody's changed. I mean, theoretically, it's the same allergens they've been mixing up for 20 years.
Are you getting your extracts from Canada, or are you getting them locally?
I mean, I was using a true test, actually.
See that if you want, there's a company out of Canada. You get all the metal testing you want. They have everything.
That's normal. Yeah, I get them from them.
And then they have cases for as many metals as you want to test for.
So they're online catalogs.
Yeah, we stopped using the true test because it only gives you 2 metals.
Yeah,
3.
Yeah,
Yeah,
cobalt,
very helpful.
Oh, what I want to do is actually put together a kit like that and be a referral source for the file.
Yep.
I think one is clearance just above the chart in a way that they can proceed, at least dismiss the patient's concerns, but sometimes I feel like I'm betraying the patient and making a test. You know what I'm saying?
That's always out there.
And then you can go online, you can get a lymphocyte stimulation study if you want to send it out, but it's be a real pain and it's not covered by insurance.
That's that Clifford thing.
Well, there's a company in Colorado too. There was a guy in Cleveland that was sort of lost interest in, but there's a guy in Colorado who's pretty sharp. He'll do the lymphocyte stimulation to different metals. I can't remember his name. I don't think so. He's his own company and his own test. But they just put lymphocytes in tissue culture and stimulate them with metals.
Every time I took, but I don't know if the evidence for that's any better than this.
Well, and that's why they won't pay for it, because the CMS hasn't validated the test. So you're sort of on your own at that point.
It comes back as a guinea pig for the insurance company.
Whatever.
Yeah.
Do you have any business cards or an email address where we can get a hold of you? Because not that I keep pestering you, but boy, I walked out. You're doing it.
Because of too much metal.
But I would love to be able to send patients to you. And all these people are coming in. Most of them, it's just weird.
This is such an unmet need in the orthopod world because we're seeing more and more of these people. They're looking for just guidance.
I
But I can't do anything but just move it away. And
You know, I think I've had this
believer actually just can't prove it. It's a really striking story. It's fine, and I'm not fine.
You're not watching that.
thing. Sure.
And what about the lichen planus people? When you have people just lichen planus, you just treat them for Hep C. Most of the time, it seems to go away. But is there any other? Actually, we should screen for?
And is most of my life.
It's one of these Whenever you use steroids diagnostically, like just give them a week of 2 weeks of prednisone and have them come back and see if their mouth is better. Because I do that a lot. So
I tend to use topicals like dexamethasone.
we use budesonide, for instance, for a lot of other things. We use it with Splendid for IV. So that's something new. Because it's got, it's significant amount of potency. It's pretty cheap. Right. You can make a half liter for 70 doses, so it's actually pretty inexpensive. I didn't think of that. That's sort of Anyway, thank you.
Thank you.
Oh, my name is Paul McBride, so if you start getting weird if you start getting weird emails, that'll be me.
It'll be very
Well, thank you.
Can I run a quick case by you?
Oh, now I know why you waited till the end.
Here's a family who I saw children. 3 people, 30-year-old woman and 2 kids. They have, knowing that managed care, we described immunodeficiency going to get delayed. Stat 1, I'm guessing, which causes chronic mucositis.
Yeah, I was sort of curious if you ordered magnitude of pricing.
They've had thrush issues. We treat that as a deal. But the other thing that antiviral is current they're pretty superficial, but they're painful. They're always on the lower inner lip or occasionally on other mucosal surfaces. They don't appear to be herpetic, usually 1 or 2.
My guess is you kind of order or so they're just for you, just like a normal
So,
pill.
how do you treat them for
people revolt for themselves.
It's the only one that's I think it's the only one that's going to be a pharmacy benefit.
He's actually on that.
The other one that our competitor's bringing out is actually going to be a medical benefit. So I don't know. Well, so the medical, it's my understanding, a medical benefit would be you'd have to go through what you have to go through to get Xolair now.
Oh, I see.
So you'd have to pre-op it.
Collagen.
You're calling yours Grass Tech, not Grass X?
Prescription Grass X.
Oh, it is X?
Grass X and Ragwitech are the names that I've posted.
Ragwitech?
Yes.
Other
Not that you'll have much
when we treat our
ragweed.
That's a ways out yet, the ragweed, isn't it?
2 weeks behind.
Oh, we're
Just 2 weeks behind grass.
2 weeks behind grass.
Oh, I thought that it was just grass this time around.
sometimes mix
No, they're
steroids
supposed
and
to follow, well, because the government shut down last year.
Oh, I didn't know they were at the same approval pipeline. All right.
They put them a day apart.
One is
Upon review. Again, it's all up to the FDA. So
They should get a mouthful. They should have a mouthful of tablets every morning.
doses of
exactly. So I was curious, who would you guys like?
very little evidence.
If I could get like a thought leader to come in for the launch of that product, bring them out the night before for those interested parties that would go out in Seattle.
I don't know, Lynn, who's
Who would be the guy that? I mean, you guys already get such big names anyway.
We have to bring the topical and I'll decide.
It's OTC.
Okay. Okay, I'll do it.
But,
I'll get a list from Helen.
that I actually ran
See,
a
Dr. Jones.
double-blind
She is.
randomized
Give me a list
clinical
for
trial
2 days.
for the drug. And it's called
I'll get you a list. We'll chat.
melts,
this year
which is available at a lot of pharmacies and on Amazon.
Is that like Orbase or something?
Well, Orbase is okay, but that just protects. This has a glycyrrhizia extract in it, and they're little tiny patches. And the guy's a local. He's got proprietary rights to this stuff. Kind of like Orbase, that'll stick. So you peel up one of these patches, you stick it on. Covers the apis so that it doesn't hurt as much. And they're randomized, double. It's a really well done study. If I do say so myself.
Yeah,
an independent second
I was
assessor.
bobbing along my
We
knee
measured
for a while, you know. So it's amazing.
It reduced the healing time dramatically. And reduced the pain dramatically. Now,
Ankles,
it tastes like licorice a little bit. So if you don't like licorice, just screw
And
it.
how are you?
But those actually work. And
Surgery,
it's OTC.
Yeah.
Can you put a little steroid under it or anything?
I think that would inhibit the stickiness.
But what I did with the Orbase is I mixed, you can mix it with
a week, I didn't see very well because the cornea was swollen.
Most Orbase is kind of gritty.
But,
That's why people don't like
You
it
know, I
so
thought
much.
magically they
But
did
right.
have it off the next day, and
But
I had
these are also
X-ray vision.
a little bit
Of
spent.
course,
So I
yeah,
don't
you
know
do.
unless you could get a prescription.
But actually,
You're,
I'm
you're
very
a
happy.
positive person,
So
that's
very
why.
But so yeah, we
it
think
looks
about
like
topical
you don't
steroids. We
have
think about
you know,
any
swelling or-
H2
H2
blockers. Now again, this is out there. I've always used cimetidine.
And hopefully not miss journal club.
And I don't know what you would do for a kid. Adults, I use about
I
6
missed it last week, which is rare for me.
And there's
I know.
not,
Did you-
there's
did you watch it
no
from the outside
really
in?
evidence-based.
I did,
Or
and
try
I
to.
heard, no, you came in late.
Yeah.
Pulling this out of my
I
butt.
learned
The good thing
that
is
it's not
since
as
mom
good
has
as
it too, I
it
can
is
try
from the
things like
outside.
her if it works for her. We
Not
should
even
try.
close, 'cause
Yeah.
you're sitting
If
there
it's safe
by
for her, we'll
yourself,
try it.
and lower the computer screen, your
Right.
brain wanders.
All right.
It's
So,
not
yeah.
interactive.
Well, I'll try this.
Yeah.
Beyond that,
Okay, you put me upstairs.
it's terrible
I can,
pain
yeah.
for REU.
That's just make sure.
I'll get
Well, it's
my
interesting. I mean, maybe it's just coincidental in this family or something, or we don't know if it's related to the gene defect.
You know, one other thing that we do sometimes is we put them on
No,
that's when their stress levels go down.
Okay,
Their REU goes down.
I have noticed it seems to occur when stress. But
Yeah, we just put them on antidepressants and it kind of knocks down their REUs a lot of the time.
thank you,
And what was your name?
Matt.
Matt. Oh, how about that? I heard there was a Matt Altman. You guys look a lot alike too. I'm not sure if that's a compliment.
Thanks again. This is, I don't know about other people in the room, but this is an area that I think most of us don't know a lot about. And people walk into our office and think they're allergic, and we don't know what's wrong with them. And even if we forget what you said, it's basically good to know you're here in town. To some people.
Sure. Well, I hope that was okay. It was very clinical.
No, it's very good. Matt, I gave you a couple of things there.
That's for the Jaguar.
One is just to put in the Jaguar.
Thanks again. See ya.
Yeah.
The other is something for your taxes, and the third one is for the bike.
Okay. So I mean.
All you have to do is press that
I
button,
guess
the
maybe
door
I
opens.
can, I might, I'll be in that area today. Should I bring some stuff to look at the brakes? Or?
Yeah, if you can work on it there and don't have to move it or anything, that'd be, it's working fine, pretty much.
Which brake is problematic?
I think the left, I mean, it brakes adequately. I just ride on that path. I rarely have to brake. I only have to cross 70, which is the only real street you ever have to cross.
Well, I need to have good brakes. But, okay.
I'm almost certainly going to go ahead with the second eye surgery next Monday.
Is it better or?
And now it's much better. It was just corneal swelling that has gone down. So I can actually see very well now. So I probably don't want to miss the next session. So I drive me.
Yeah, I think the worst days I have another meeting
Okay, well maybe Mom can drive me. Let me see what the presentation is. And now I'll have to time through it. I see that. I just need to
So, okay, so this system shut down, and then hit it twice. Yeah, you have to hit it once, and then you have to wait for it. Yes.